Quick disclaimer before you listen. The World's Okayest Medic Podcast is an educational and commentary platform produced and recorded by me. What we say on here is not endorsed by any of our employers, and we are not speaking on behalf of our employers. Our commentary is our own. Finally, remember to follow your local protocols.
All right, I am here with Cody and Sam. You all know Cody. Cody, last time you were on the podcast, we created quite a firestorm with...
Yeah, we almost got canceled.
You're saying that we sometimes need to chew ass when we're field training people. But we're here to talk about something else, and that is a topic that I know absolutely nothing about, which is why I wanted to have both of you on. Sam, people have probably seen you because you have a burgeoning social media presence. Why don't you tell us about yourself? People know Cody already. We lost him.
So I'll give you a quick overview. So yes, I had been in EMS for almost 10 years. Throughout those 10 years, I started off volunteer, small town. And then, as I continued to volunteer, it quickly turned into, obviously, now my career. I kind of jumped around. I got really curious into I did a little bit of metro, on the truck in the metro, did some rural stuff. I was in the actual ER down in our Trauma 1 center in Des Moines. So just kind of jumped everywhere, just loved to get a feel for a little bit of everything. Went and got my paramedic, then my critical care, and then landed down in rural Iowa doing truck and obviously mobile integrated healthcare down there now.
How long have you been doing the mobile integrated health thing?
Counting the program development, which took an awfully long time, it's only been about a year and a couple months, so not too long. So
I don't know of many community paramedics that have a ton of experience doing it because it's such a new area.
Yeah. And that's it's interesting to see, the more I got involved in this, it just seemed like there's some secret ones that have been doing it for so long. They call themselves community paramedics, but they were been doing it before it even had a name. And so, they kind of created it and not even having the official community paramedic title. But yeah, it's definitely a very new field.
Because I don't know anything about this, is community paramedic and MIH like interchangeable? Is it synonymous?
Yes, as far as I'm concerned. I don't want to make a statement there, but it does seem like it's very synonymous. But I would say mobile integrated healthcare, and the way I try to explain it is it's more of the framework, and the community paramedicine is the provider. And that's the way I look at it. It could be looked at different, but that's how I kind of sell it.
All right. And Cody, besides the fact that you and I are friends and you have a podcast, and I think you're a great resource, do you want to tell people why you're here to talk about integrated health?
I just recently made the jump about 2 months ago now.
Was it a mandated jump, or was this voluntary?
My body said I had it. No, no, it was an advertised spot within the organization. It had been something that had been on the organization's radar for a little while, and finally they had gotten to a point where they could actually support doing it. And it was one of those, we're tired of talking about it, let's get it done kind of thing. So, I threw my hat in the ring and wanted something different. You can only do the 911, take people to the hospital thing for so long without having something on the side, right?
You mean like
flying or forget. I forget my audience have to be specific.
Okay. All right. So I don't know jack squat. This is like the 14th time I've said this. So I'm just going to let you two talk about mobile integrated health. I don't even know how to lead a discussion about this because it's such a foreign concept to me. So Sam, I would say, no offense, Cody, that of the three of us, you're probably the subject matter expert here.
That is saying a lot.
Why don't you take it away?
It's kind of, I don't really know where to start either. It's such a loaded concept. I feel like I live in it every day. It's hard to really put at a high level, but.
Okay.
Tell us what it's not.
What is it not? Yes.
Yeah. Tell us what it's not.
Excellent question.
Yeah. Well, and that's, I think, a big misconception, obviously. And maybe not obviously. It's hard to talk about it on a broad scale because I think in every state it's so same and different. So I'll try to not generalize a lot. But when I started up mobile integrated healthcare, a lot of times it was misconstrued as essentially paramedics doing home health. And right, not that there's anything wrong with doing home health. Home health is a very great resource, but it was a lot of times looked at as, well, why are we doing this? It's a redundant service that's already existing. So that was a big kind of defense, I guess, that we would always talk about. But it is not home health. It is actually, and the way we are framed up is we look at it as it's a short-term service or a transitional service from our patients that are, whether they're getting out of the hospital on discharge, they're high ER utilizers, or there's multiple other instances. We're taking them into a program. We're setting goals, setting objectives, and our goal is to provide some sort of foundation or service to get them into whether it's a better outcome or finding a long-term service for them, which could be home health, which is a long-term service for them that may help them, whether it's clinically or socioeconomically. So that's the way I look at it. I like to say transitional, whichever way that looks like. We're trying to get you out of the ER every week, or we're trying to get you, healthier, or just off to a better start socially. And now that could
Cody,
be
what are the
different though. Other programs kind of focus on maybe more supportive services and things like that. So I think that's why it's kind of hard to talk so specifically about mobile integrated healthcare, because a lot of programs do it so differently.
What are the goals of does your agency have specific goals? Because the agencies around me that have buy-in from the hospital systems, it seems like I frequently hear about heart failure patients. And it's like we're looking at heart failure patients and keeping them from being readmitted because it's, one, it sucks for them. It's not good for them. And two, if they get readmitted, we don't get reimbursed for it. So it benefits everybody to keep them out of the hospital. So around me, it seems like heart failure has been kind of the experiment and the springboard to get it done. Has that been your experience, or is there another target area, or is it more broad?
Yeah, I'd say CHF and COPD are probably the big diagnosis that we see. The way we based our goals or objectives for the program, or our buy-in really for our hospital administration, was what our ACO measures looked like. And so that's really based off readmission and the diagnosis that are hard hitting on our readmission percentage. And so, we looked at it, and ours was COPD and CHF. And I think that's kind of where it's coming from, is a lot of these hospitals are looking at it as those are just the highest risk for readmission, those type of diagnosis. So, but I would agree. I think almost every community paramedic mobile integrated healthcare program that I've talked with, they have at least CHF or COPD as one of their top diagnoses that they focus in on.
What are you guys looking at doing, Cody? I know our mutual ER nurse friend who's a leader in the local ER, she was saying she was going to be meeting with you to discuss like how to, I guess, hone in with the program you're developing.
Yeah. So my program's got basically 4 buckets that a patient will fit in. And the first one is, it's been going in my organization for a long time. It's their PORT program, or it's the overdose group. Whenever someone overdoses, these 2 folks, one's a peer counselor and the other one is she's a caseworker, and they interface with the folks and find out what resources they need and touch bases with the families, which is a big deal. You've got little kids who watch grandparents or parents, overdose right in front of them, and there's no counseling for them. There's no outreach for them. So they take care of that part of it. The other 3 buckets are kind of my world. The first one is it's the 911 high utilization program. That's the one that's probably the less, what's the nicest way to put it? It's like the less sexy one, because you go into somebody's home and you find out that you keep going to the ED because you don't have a primary care physician. So now we're basically going to connect you to those other clinical resources to keep you from utilizing 911 and the ED as your healthcare network, because there's other stuff out there for them. Yeah. And what I learned, a few years ago, we did this back in Texas, and doing it here was, that's the most expensive way for someone to get healthcare, is to call 911, get loaded in an ambulance, and get taken to the ER just to be told you're not dying tonight and you need to go talk to your PCP. And, 3-4 days later, it's the same song and dance for them. There's a post-acute care observation folks. These are the readmissions, the folks who came in for CHF, COPD, or yes, all of the above. And the hospital has a very, very keen interest in keeping those folks out. One, because their outcomes are better. They do better when they're not in the hospital. And two, to your point, Sam, is that they get penalized for that. The patient doesn't get penalized for it, but the hospital does.
Hospital does, yeah.
And then finally is it's the low acuity, I call it the LACE program. It's the low acuity complaint evaluation. So this is the one that wakes us up at 10 o'clock at night. You're like, are you fucking kidding me for a headache? And so that's where we would intervene. And this one, and I'll say this right now, this one is not ready for prime time. There's still a lot of work that needs to be done from a policy perspective on our end for us to launch that. But we would be able to go out, hear the 911 call, or even be co-dispatched eventually, and go and see this and go, all right, listen, we're going to navigate you to a different place. We're not going to say you don't need to be seen by a physician. We're not going to say you don't need medical care, but we're going to take you via the most appropriate resource to the most appropriate resource, and try to offload the ED in the 911 system. So that's kind of how we're set up.
Do you have anything you want to add, Sam?
I mean, it's awesome to hear that. I think that it's, like I said, everyone I feel like is doing the same thing. It's just they all have their different ties to it, because it's really based on your system or your service area on what's going to benefit the most. Because at the end of the day, and that's what I think I really enjoy about mobile integrated healthcare, is does it benefit the hospital in some way without being penalized? Absolutely. But every goal or every outcome or measure that we're really pushing for is actually for the best of the community or your patients as a whole. And I think, you were talking a lot about the lesser sexy, just the resource connection with your high utilizers and things like that. But from the beginning, I've always vouched for social work and social workers to be involved in mobile integrated healthcare units. I think the dream team is a paramedic and a social worker tackling these different calls, because I think they can handle those type of not just the resource connection, because you can hand anyone a pamphlet and say, here you go, stop coming to the ER, please. But our social workers can really, we don't get trained on that stuff. And just to watch them, I've talked to a few, there's some in Colorado, programs in Colorado that utilize a paramedic and a social worker team. And to hear the type of work they do, they just are able to kind of get through and resonate to those patients and build that rapport that we just aren't trained quite to do. But we have that kind of same setup, and eventually the goal is to get social work involved, but that's got to show my worth first and then get down the line. But it's a lot of resource connection. So a lot of people I think look at it as a softer job, I guess, a softer paramedic job, especially in our field. But it's once you kind of get into it, I think you see it's not. I think it's hard for me to explain, but it's very much you are pushed or more challenged, I would argue, from just a skill and knowledge standpoint than I've ever been in the back of the truck. So, but it's kind of hard to put words to it a little bit. But
it's like, and even I didn't have an appreciation for it for the longest time. But it's like, do you know how good you have to be to prevent the 911 emergency from happening, and what you need to be aware of and what you need to look for and see? Like, all right, listen, if we don't get this under control right now, this patient is going to have an actual emergency, not just a nonsense utilization. It's going to be an actual CHF exacerbation, COPD exacerbation. And if you're on your game, you can see those things. You can see those things coming and put a lot of resources in place to prevent it. And you've got to be good, man. You got to be good. I'm not that
and you made a good point. Yeah, you have to be on your game. And it's the weight. I've never felt that before. And even, I've done some pretty wild stuff in the back of the truck, and the pressure is just different. It's more long-standing. You kind of feel, you're building a rapport with these patients. I've never appreciated primary care more, just the way that they build rapport. And, I've never really understood that. I see patients and I'm like, yeah, we're getting this done in 15, 20 minutes. We got to go. And right, we get down and dirty and we're done. Building this rapport with patients and then feeling the boundary setting is very, you learn that quickly,
Yeah.
making sure that you're right, not turning into a family member with now the medical power of attorney of your patients.
You didn't give your personal number, did you?
Once or twice, and then I learned my lesson, but it's all lessons learned, right? No, I think I have much more of appreciation for those people that do the long-standing relationship and rapport to have the weight of, I have patients call me and they ask me really questions. I'm like, I get that imposter syndrome a little bit. Like, I'm not qualified to do this, but you have to be, like you said, on your game and confident and ready to show up for your patients. So it's just a different way of pressure. We're all used to pressure as paramedics, but it's a different type of it. And yeah, takes a little bit of adjustment.
We are from being a 911 medic, we are so concerned about liability. Like I know you, like my daughter, she just had field hockey practice and she has back pain. And my wife and I were like, you need to take a hot bath, you need to stretch and go to bed. You guys know that if this was a 911 call, we would be telling the parents, like, she really should be going to the hospital because
could be a kidney stone.
She could have, and she could have, God knows what, she could have like meningococcemia. Worst case scenario. Mm-hmm. We are so hyper concerned about liability. And I think there is some good reason behind that. Mm-hmm. How do these programs balance the liability? Like, let's say you get that heart failure patient who calls and they say like, oh, I haven't been taking my medication, and you maybe hear a little bit of crackles. Maybe they have some ankle swelling, but they're not like acutely sick. 911 paramedic, mm-hmm. I'd be screaming, you need to go to the friggin' hospital. Like, I can't leave you here. Like, I'm not saying I need to do the royal workup on them, but how do you guys balance that? Because you all know you call medical control, and I don't know if you call medical control as a community paramedic. They're going to say, oh, they got to come in. They got to.
Yeah, I would say, on my end, I think I'm just really lucky with where I'm at because we're a critical access hospital in a small area. So we all know each other very well. Our paramedics, so our 911 system is operated outside of or inside our hospital. So we're already very integrated as a 911 team in our hospital. We do, we're assisting with all, ICU patients we have. We're assisting with all rapid responses, any traumas that come in. Our paramedics are looked at already as kind of a critical care team in our hospital. So the trust between myself and the providers was already there when I developed this program. So I was able to come off each other very, I'm able to call them. They're able to give me some advice if I'm kind of not feeling good about something. We're able to work through some things. There's a lot of trust there. And I think that's pivotal in a program. And I think that's why I stress so much about the integration aspect of being truly a part of the patient's care team, and having that trust just benefits, and you're able to do so much more than where in a traditional 911 medic, it's like we either go to the ER or I maybe possibly get sued my license gets taken away because of the ABC possibilities that could happen. Instead, I would argue that my providers, they champion it and they take the sole responsibility. We technically still run under our medical director, and it's that trust that we're all in it together and doing it for the patient. And yeah, we kind of have each other's backs. So I would say I'm lucky on that side of it to have that type of support to really maximize what I'm doing. And I can give them a call and I'm kind of like, I just feel weird about this. They're like, all right, well, let's do some lab draws. Let's do this. And I'm 5 minutes from the hospital because, again, small place. And so we can go do lab draws. We can really assess the situation for what it is and then kind of go from there. But yeah.
What about you guys, Cody? I know it's still in the development stages.
Yeah, there's a couple of ways that I talk about it, and both of them it's about risk, right? Like the way I talked to the group the other day about it was like this, and I'm stealing this from a presentation that I was at earlier, but I was like, I'm using that for everything. So it's risk is a function of the probability that something's going to happen and the consequences that something's going to happen divided by the mitigation, right? So if you know your patient has a high, that has a multiple comorbidities and is a really high risk of readmission. And if they do come back into the hospital, then that is definitely one of the, that's definitely a penalty. And those, so you've got that stuff. And then you've got your mitigation strategy. And we, MIH and community paramedics, and however those teams are designed, we are that mitigation strategy. But that mitigation is only as good as you allow it to be. So if you put community paramedics, and there was one program I rode with, and I was a little bit like, this is what y'all do? That's it? Kind of thing. And then there was, when you talk about other programs, like the programs down in Texas, or folks that are carrying iStats and stuff like that, and people are going, what? I said that in one of my initial meetings, and it blew everybody's wig off, because they were like, oh, we've got to talk about policy, we got to talk about all this, that, and the other thing. And it's like, well, if you want this to be as effective as possible, then you need to learn to be more, and this is the other thing of risk that I talk about, is be more risk adaptable. So risk adverse, I'm going to shield myself away from, everybody goes to the ED. Risk tolerant would be, maybe that one can go to an alternate destination. Right? We can take that one to a crisis center or a detox center or a standalone ER. So more risk tolerant. Like, not everything has to go to the ED in an ambulance, but they do need to be seen by somebody. So risk adaptive is, we're going to reimagine outpatient care, and we're going to put a paramedic social worker team, or a paramedic nurse team, or a paramedic no social worker team in the home. And then we're going to do some care coordination. And then we're going to try to get them into a specialty clinic. And then the ED is the option. And at that point, that readmission is unavoidable. You should be able to look at that situation and go, unavoidable. That is a mitigation strategy. Not simply giving a paramedic a new title and saying, okay, go prevent readmissions.
Here's your pamphlets.
It doesn't really work that way, right, Sam? Yeah, here's your pamphlets and here's your handouts. And
that's my question.
Yeah.
That's my question. Yeah. From the perspective of a field provider, there's a guy, he's got a legitimate cardiac history. He's got like 247 stents. He's been cathed 800 times. And he calls nearly every day for chest pain. And the one time you blow him off is going to be the time that he has the big one. So that's my thing. Like, there was talk, okay, we don't have community paramedics, but another service in the county does. We're going to write up a contract with them to come see this guy. And I'm like, that is all well and good, but like, what kind of effect is that going to have on him? And that's my question for you guys. Like, I don't want to, I'm naturally kind of a cynical guy. It's a character flaw, but what
every
would you
EMS
say
provider ever?
Yeah. What would you say to that what would you say to that paramedic though? And I think it would be a sizable percentage. Like, all right, like, Captain, that's all well and good that you're having a community paramedic go to this guy, but how's that going to change us going to his house every day at 2 when he calls with chest pain?
Yeah. I think so. For me, again, kind of like what I was saying, our system works so well because of our size and kind of where we're at, like we were saying. So there's like this mitigation plan that we have in place. So I'm able to look at, for example, I have a patient, and he's very complex, a lot of comorbidities. He's a sick guy. I'm not curing him. I know I'm not curing him, but there's always these deeper things that are kind of going on. And you kind of look at it from the whole picture, right? I could spin my wheels for a year trying to help him on A, B, C, D, E, F, G. But you try to look at a bigger picture. What is it that's going to help him? It's not going to cure him, but what is it that's going to help him, stay from, okay, for example, so he would come into the ER almost every week. It was always low blood pressure. He has low blood pressure. He's had it for long time. He was being brought into the ER by care providers, neighbors, care aides, and he was so worried about this low blood pressure. It was as simple as going in and talking to him, and not about all of his comorbidities, not about his extensive heart history. It was really just talking about blood pressure education. And he, immediately took, away from going weekly. I think I've seen him maybe now once, maybe twice. in 2 months. It's like little things like that that can help. Now, those really sick patients, it's such a case by case basis, but yeah.
You have to
I
help
wish I
them
had the
understand their symptoms.
This guy, I'm going to go
and
out on a,
it's
and I know you can't like opine just from what I'm telling you with, because every patient's different, but this guy is
yeah.
also, despite his like legitimate illness, he's manipulating the system. Like, he's bored. There's issues with his wife. He's working the system. So is that more of a social worker thing, or is that more of a community paramedic thing? Like, where does your role come in for somebody like that?
I'll be honest, not every patient is a community paramedic enrolled patient for us. So we have a specific criteria
Yes.
Very
and
fair. Very fair. It's a good
yeah.
point people need to
So we
hear.
can't help everyone. Yeah, because I would argue,
Okay.
I mean, in rural Iowa, we see that all of the time where there are patients that truly just, I mean, they'll blatantly say it. They're like, I will not change my behavior. I will not, and it's like, okay,
Oh yeah.
unfortunately, we have no business really trying to spin our wheels then. Yeah, unfortunately, that's kind of just the case you got to live
Yeah.
with. But
Can you
You know,
discharge patients?
hmm yep.
it's
So
actually a discriminator. Go ahead.
yep, yep. Yeah, our system's set up on a referral-based system internally, so strictly internally. And then I go through the criteria. I essentially say, yep, they can be enrolled, or nope, A, B, C, D, F, G. But the big thing is there a positive outcome that could come from them being enrolled? Is there something we can do for them? But yes, it's not every single one being enrolled and then we're helping.
Yeah. Like we can't help it that patient X is 372 pounds and they can't get around their home. Nothing we can do for that.
Hmm
I mean, there's no amount of
hmm
installing, shower grab bars that's gonna prevent, this individual
Yeah.
from needing health care. Um,
And it's not to say either, sorry, I should say, it's not that we're saying like, "Nope, not you, not you, not you." There's a lot of times I'll go
yeah,
in and do a first visit, and you can tell, and I don't real it's not really easy to identify why, but, like, you can tell if they're motivated to help themselves or not, and if it's going to benefit them having an additional person in their care team. It's pretty easy to see off the bat, and that's kinda how we go off of it most of the time, but, sorry, didn't mean to cut you off there,
so,
Cody.
no, you're good. I'm similar, although I'm not directly
Mhm.
integrated with a healthcare system. So all of my
Yeah,
referrals are technically external. And what I learned
right.
early on was that, man, if I don't have some way to triage patients, that I will simply be chasing my tail, chasing
Yes.
chasing down, patient X who's called 87 times. And really what it is the line guys are tired of dealing with them, and they think that I'm going to
Yep.
fix that. Unfortunately, that's not the case. So what I do is I'll take the referral, I'll take it in, and then I score them. I'll use the hospital score and the LACE index. And if
Yep.
they are actually by those scores, a high risk readmission, I'm going to go on out and do the thing, because there's way,
Mhm.
way more of those patients than there are the ones that are, to your point, Mike, that are just abusing the system. But
Gotcha.
what you can do, and what community paramedics can do, is they can go and see the patient, do the thing, do their assessments, see what's what, and maybe even make an attempt to
Mhm.
modify their behavior. But what you can do is you can give that chief or that executive or whoever it is that makes that decision the confidence that they can sit across from that patient and have that 911 abuse discussion and say, we're not doing this anymore
Yes.
because I've given you everything I can, or everything that I have available, and you refuse to meet us halfway on this. So here's the new rules for you, the individual. And you can give your boss that kind of confidence.
Yeah, and you made a good point too, saying, right, there's surprising, and I will always say, like, coming from a 911 truck and then moving into this, my empathy, or I guess my insight has grown exponentially, because I agree. As a 911 provider, you get very burnt out on those people that you feel are abusing the system. And that's, I think, what's been so neat to see coming into mobile integrated healthcare is I'll have, the guys on our truck, they'll bring me a referral and they'll say, oh my gosh, this is the sixth time we've seen this person. And we're getting really frustrated with this because it seems like he's just wanting to call us for little stuff, the toe pain call. I'll go there
Mm-hmm.
and it's an obvious, well, he's been debilitated for so long. Yeah, and he's too afraid to say it. The best thing he can do, or the only thing he has, is his cell phone, and he knows 911. And right, going in there, you see this is an easy fix. Actually, it's just we had to allow our paramedics to the chance to actually go in an appropriate setting, not on a 911 call, on a more, I guess, extensive, time centered call, and go in there and kind of look around, see what's going on, and see and not only that, but then give them the resources to say, okay, well, either go to, we don't have to say anymore, either go to the hospital or, right, you sign this refusal. I have now an entire toolbox of tools, resources, options. We can connect with the primary care. We can do stuff at home. It's a lot different, and we can kind of move more into a comprehensive role versus just the black and white.
And so to maybe paint a different light on it, I looked through my top 5 utilizers in our system because I was thinking maybe I'll just farm, I'll mine some patients out of there and see what's what. And like my number one utilizer had 31 visits month to date. When I pulled the data last month, 31 times. One of the other ones was only 10 times month to date. And I go, well, what's the difference? So they both had CHF. They both have hypertension. They both have some hyperlipidemia. One patient has COPD on top of it. The other patient has a very, very complex mental health history, anxiety, depression, bipolar disorder. And what the data will tell you is that those patients who have these ambulatory care sensitive conditions, when they have that, and then you add a mental health problem on top of it, there is 10% more ED utilization in that group than the other folks who seem sicker. And because there's a misconception that, well, the number of times they're calling 911 is a predictor of readmission, and it's not. When you put them in the scores, when you score them, hospital LACE, whatever it is that you're going to use, you'll find that that mental health person with their medical history actually has a really low chance, really low prediction for readmission. And I think that patient's LACE score was like a 10 versus the other patient whose LACE score was 13. And that individual's, there's something called a Charlson comorbidity index, or comorbidity index. And that looks at all of your diseases. And it says, this is your survival at 10 years. Patient A with the mental health has 90% survival in 10 years. Patient B with 10 calls has 53% survival at 10 years. So I'm going to try to resource, to your point, Sam, I'm going to try to resource patient A with all the mental and behavioral health stuff that I can, and know that, the symptoms, those folks, the symptoms, they're more easily distressed by those symptoms. Chest pain, I'm immediately dying. Chest tightness, like when I started taking lisinopril, man, I thought I was like, whoa, is this chest tightness? Is that what that feels like? Or the wet cough that you have all the time that makes your chest hurt. I kind of learned a little bit. I can see the patient where they are now and say, okay, is this medication side effect, or is this something new? Is this something real? And when you have a behavioral disorder on top of it, your brain doesn't process distress the same way that somebody else would. And so you try to resource that individual the best you can, and then, focus your attention where I think, at least in my opinion, where you have the greatest yield. And that's the other patients.
Yeah, I could step on a soapbox, I think, for the correlation between, mental health disorders and chronic disease and how they can exasperate each other. It's astonishing to see that, truly, just how, a simple anxiety condition, how that can, just wreak havoc on someone with a chronic condition, especially if these patients don't quite understand when they hear, oh, you have congestive heart failure. All they hear is, my heart is failing. like, what? And they will go home after that diagnosis and throw themselves into a fit and just be, and
Mm-hmm.
that's right where we then see them at 911. It's like, what are they, and you instantly think like, oh, they're fine, but that's very real to them. And it's very to see that, and just to see that it's more of a, oh, you just need to be explained on congestive heart failure a little more. And that can actually, how, again, it's such a little thing, but the trajectory of it completely changes the trajectory of their now chronic condition, which, right, I mean, exasperations, they have a massive impact on the rest of the quality of their life, every single one of them. And if all you have to do is give them a little bit of education, discharge education, to completely change that trajectory, that's actually pretty incredible. And not to mention the ROI on that for hospitals is, it's pretty easy sell when you kind of look at it in that way. But no, I really enjoyed you. That correlation's huge, huge.
So I want to float something by you guys. And so we tend to think of stuff like PTSD as something, an event that I witnessed or event that I was a part of that distresses me to the point that I thought I witnessed death, see death, that kind of stuff. And it alters your, the way you perceive those kinds of things. So imagine the first time the patient had chest pain, or the first time they had the heart attack, or the first time they had a CHF exacerbation, and they literally thought they were going to die. Well, just because they're symptomatically, they're better or medically stable, it doesn't mean that that event did not alter their perception of, I feel okay and I'm finna die. And there's a trauma piece to that, man. And it can be so distressing to these folks. And I'm saying this for all the cats who are, awake at 2:00 in the morning going, man, I am so tired of this call. And it's like, well, no. Get yourself out of it and think about Miss J. And Miss J has had 4 heart attacks. She was told, every time she goes, she's told how close to death she is. Meet her there. She's scared she's going to die.
I do get compassion fatigue is a real thing in this line of work.
Yes.
And I have found that as I approach my mid-40s, come here, Ange, say hi. Thank you. I'm such a shitbag. I just texted my 9-year-old on her iPad and was like, hey, can you bring me the wine? Say hi.
Hi.
All right.
Dad's got to talk about MIH for an hour. I need more wine.
Yeah, seriously. No, but compassion fatigue is a real thing. And I have found that as I have gotten older, I am more attuned to being, I guess, nicer is really, like, I hate to say I wasn't nice, but I guess nicer is the way to put it, and being more understanding. Like, Cody, that is a real thing. Like, that little old lady who calls wigging out at 3:00 in the morning, who is fucking fine and is in a panic because she had a twinge of chest pain, like, that's a real thing. So is that somebody you could intervene with? I mean, because here's what I think, because what happens in the 911 world, you say, oh, all right, you're 85 years old, you have a cardiac history, like, your EKG looks fine, all your vital signs are picture perfect, but you need to go to the hospital because I can't deduce that you did not have some major medical problem that is hidden, blah, blah, blah. And then she's going to freak out. She's going to go to the hospital. They're going to 90% of the time find absolutely nothing wrong with her, or they're going to find some completely unrelated lab value that's off and then do like $1 million workup on that and then find that nothing's wrong. And she's going to pick up a GI bug or pneumonia from being in the hospital.
Yep.
Yes.
So are those patients that are worth intervening? Another thing I was going to say to tie all of this in is that my wife was an ER nurse for like 10 years, and then she became an MP. She worked primary care peds, and now she works from home doing telehealth for a national company. And she said she's like board certified. I don't know how many states, but she sees like patients in Arkansas, Delaware, New Jersey, California, all over the place. And she says it wasn't until she was in this role that she realized how many otherwise intelligent people have no health literacy whatsoever. She's like, you know, she's like, yeah, you know, you're used to the ER where you get some like, you know, some dumbass come in who's got 3 brain cells and they don't know anything. She's like, but these are like lawyers. She's like, these are school teachers and engineers. And I'm like, teaching them stuff that I thought was basic, and they're freaking out. And they're like amazed that just a little bit of knowledge can put them at ease. So I rambled a lot. So discuss.
Yeah. Well,
It's
and
like a little
I think it's
reassurance.
yes, and I think it's for us as 911 medics, it's easy for us to forget that people don't live in trauma for a day-to-day activity like we do. Our tolerance to that
This is
type of
true.
stuff, yeah, it's profound. And I think so right, I got the chance to not only I experienced that and now I have the tolerance for that, but now I get to step out of that and look at it from a different lens almost and see what these patients, right? I talk to these patients and like I said, like congestive heart failure, where they're like, my heart is failing. Like that's scary. I'm like, you're right. That does sound scary. Let's sit here and talk about it for 5 minutes. And instantly that's completely turning their point of view and their anxiety and everything. And it's just this massive snowball effect of a positive snowball effect of what that's doing. And kind of as we talked about in the beginning about this, it's a non-sexy part of it. It's true. It is. It's not necessarily, you're not needle being anyone. You're not, you know, throwing in the tubes. I agree, but it is medicine. I think I've practiced medicine. Well, I'm a paramedic. I don't practice medicine, but you know what I mean? And I have done more of that than just in this longitudinal way than, you know, I feel I ever really did on the truck. It's like I get the chance to really make this impact and see it, versus, and I do, you know, we still do, I'm in our program, we do a lot of, you know, whether it's right when they're discharged, we're going through different meds and things that we can do at home. We kind of have like a soft hospital at home program or piloting. So things like that, we still get to do those type of things and skills and practice those. But it's kind of seeing the full picture. And I will argue, you know, putting paramedics in that care team is what's providing the biggest benefit. And I think that's why I push for it so much. I feel like I talk about it all the time on my videos and stuff because that's kind of the bread and butter of it is when these paramedics, right, they have this unique perspective and skill and ability. We've always just kind of been on this outside, but bringing it in and coming comprehensively talking. So now you have your paramedic, your mobilized unit, you have your primary care, you have your ER or hospitalist, doctors, all that have touched this patient, and now you can all collaborate and you filled that hole of where these care teams are saying, they went home, I thought they were fine. They, you know, they passed all the discharge. What's going on? And then right now we're able to say, well, yeah, you told them that their heart was failing. They freaked out and they essentially sent themselves into a tizzy and now they're in the ER. So we're able to step in and stop that and completely, you know, change that trajectory and move it in a more positive manner. And that's huge.
Yeah. The reassurance is it's so massive. Is being able, and to your point about bringing the paramedic piece of it in my opinion, it's always been the missing link in community health programs, community health departments. And I'm always like, well, if you have an EMS department, why do you have a community health department? And when I started to meet with they're a partner agency in my program, and I started to meet with them, and it became very, very apparent. They're like, listen, we understand the community health aspects of it and healthcare literacy and access to this and access to that. We understand that. We don't operate inside someone's home. And it's kind of like, you know, when you go to buy a car, they call it setting. You know, where they bring you to the office and they take your keys from you and they hold you hostage. So you just make a decision by the end of the day. Right. Well, the same psychology works with a patient. When you allow them to be in their home, in their comfort, they don't have to worry about bothering their daughter to take them to the appointment, and they jump through all the hoops for that 20-minute, 40 if you're a new patient, but that on average a 20-minute clinic visit where they're asking the questions, not you. They're asking the questions. Do you feel this? Do you feel that? Do you have this? Do you have any other health concerns? And you're like, well, well, yeah, I have all right, cool. So we've renewed your meds, and like you get cut off all the time. And what we get to do is we say, I've got an hour and a half for this. Fire away. And you
That's
get
my
to let
partner's
them.
Cam's normal scene time. I'm just joking. She's gonna listen. She listens to this, so she's gonna. That's just me being. Sorry, Cam.
But yeah, it's listening, being heard, and then when you hear things like for me, I'm super sensitive now to people that their symptoms make them feel anxious, or they're prone to panic attacks or anxiety attacks because of what they're going through, because I know how that felt. And all I wanted was I wanted an EKG machine so I could look at it and make sure my heart wasn't exploding, or I wanted to take my blood pressure, and I'm not gonna lie, I wanted to go to the ER for no other reason than to have some professional tell me, bro, you're okay. This is what's going on. And we get to do that.
Yep.
Without loading them in an ambulance and taking them into the ED.
Do you find the ED to be a drag on the community health program, or are they like an integral part of the mix?
That's a referral source. If you play your cards right, that's a really good referral source, and they can say, "Hey, come talk to this person before you leave," and see, build your relationship there, so you can catch them at discharge. And do you guys do that too, Sam? Do you guys catch them at discharge before they leave the hospital?
Oh yeah, yeah. Our EMS room is a hop, skip, step away from our ER, so I'm always there, and I obviously operate out of the hospital, so our ER is. And like I said, again, our critical access hospitals are, putting paramedics in these roles, it's a game changer. I can say that so confidently because I just see it every day. And my ER provider is also my medical director. He's also a hospitalist. It's because we all play these different hats, different roles. So we benefit all off each other. And so, like you said, it's a major referral source. And yeah, it's huge. But I will say,
Cody, I don't. Good.
I don't know, we hear there's a lot of truly like fire-based EMS that are starting community paramedicine programs. And I don't have a lot of conversation history with a lot of them, but I would be curious to hear their perspective on that because, I think I have such a positive and impactful light to MIH because of how integrated I am into our program and our system. I'd be curious to hear their point of view because, for example, we have a Des Moines unit down in our metro, a mobile integrated healthcare unit, and they're purely fire-based. They're Des Moines Fire unit solely. And their biggest pain point when I did talk to them was integration. They said, yeah, we see these patients and, we give them, everything we can and do the resources, but they're not connected to our big hospitals in the metro. So they don't see the full care pathway. They don't have the connections that we're able to do to truly carry out our impact, if that makes sense. And I think that plays a big part in it.
Yeah, there's like three types of programs. There's the hospital-based integrated program, and correct me if I'm wrong, Sam, but you have more in your clinical box to do for patients.
Yeah.
And then you've got what you're
Absolutely.
talking about are the big city fire-based, not even big city, but the fire-based that aren't integrated. They're trying to do this all on their own, and they probably got a couple of good ED folks that are in the mix potentially, but it's not really it's being driven by the fire department, not driven by the hospital. And what that does is it leaves those fire departments that are going out and doing this really with more of the social aspect of things. They're the ones that are putting in grab handles or changing smoke detector. Yeah, resource connection, SDO, or social determinants of health kind of stuff.
SDOA.
And the third program is the one that puts those together, right? That have a good solid clinical piece of it and can address the social determinants of health piece of it.
Absolutely.
I would venture that if you were to do a poll and say MIH is soft medicine and it's less than, you're probably going to get those responses that are going to be from the folks who, not necessarily just fire departments, but they are completely non-integrated with a hospital system type of programs, and they're not really getting to do it.
By the moronic comments I got today on my post about only decompressing tension pneumothoraces, I would not be surprised if I got a lot of stupid responses on a poll.
Yeah.
Mm-hmm. I would, and I think that's that I could go on a soapbox again because I agree. I think we live in an adrenaline junkie field, which is okay. That makes some of the best medics. That makes some of the people that are saving lives, and I fully agree. There's a space for that, but that doesn't necessarily mean that that's the only thing paramedics or pre-hospital providers should be able to do. I know a lot of pre-hospital providers that they are worn out from the no sleep, the running, the lifting, the heavy loads. There are people that could benefit from doing something that doesn't require the constant toll on your mind and your body. I don't know if that, and this is a little more on kind of the policy side and the education and more of the operational side of the framework and the possibilities of it, but right. I think it gives paramedics the opportunity to do more than just because, right, there are people that just love that side of it. And I fully agree. I also love that. But I also advocate that that shouldn't be the only thing we're allowed to then eventually do to make a living. You see, nurses have a full spectrum of what they can do. And yes, some of it is softer than others, and I don't think there's anything wrong with that. I think paramedics should be given the same opportunities. So there's benefits to the softer side. And I agree that MIH is probably, you're not throwing a chest tube or doing a tube soon, but you're doing something different and you're learning and challenging more your clinical depth.
I like that you're selling that it's higher level medicine because I do. Listening to you guys, first off, I hope you don't interpret my silence because I'm just listening to you guys talk, like I'm soaking it all in. But you guys have kind of convinced me that it is higher level medicine because when I went from 911 paramedic to critical care paramedic, I was like, I'm not doing half the shit that I used to do on the street because it's more cerebral. Showing up, you're doing thinking things. Like a lot of times the skills are already done. So you're not doing RSIs, you're not doing the IVs, you're maybe titrating some meds on the pump, but it's more of a cerebral game. That's kind of what this sounds like. It's like putting a puzzle together. And I have always said that the more I learn in medicine, and you guys kind of alluded to this, the more I learn just how friggin' smart those internal and family medicine doctors are. Is it sexy? Hell no. But they are cutting through everything and figuring out what actually happened, what's the best course of action to take with the patient. I had a patient, we do follow-ups on the flight team. And so we had this guy, he fell off a ladder. He had all these ortho injuries. And he was saying, he's like, I climbed to the top of the ladder to clean my gutters. He's like, I had a dizzy spell. I clung onto the ladder. I thought I was going to pass out. And he did pass out. And he fell off the ladder. So I'm reading his chart later on doing the follow-up. And they consult neurology. And it's like, oh, this is like probably a new onset migraine with vertigo. Evaluate for this. Cardiology's like, he clearly had an arrhythmia, put him on a Holter monitor. Whatever ology said, it's probably this because it's so siloed. And it's like, don't you guys fucking communicate? And it's the internal medicine doctor's job to be like, this is ultimately my patient. So let me look at all of this and sort out what's the best plan of care. So I actually was talking totally unrelated to community paramedicine about this very thing and this patient I had in this follow-up last night to a coworker. And he was like, oh, that's what our community paramedics do at my part-time job. He was like, we have a whole community paramedic department. He's like, they'll go into the hospital chart and they will see like, these doctors aren't talking. And he's like, they'll facilitate them talking. He's like, it's totally a paramedic driven thing. He's like, and the insurance company is also able to access that chart. So it's like if the hospital wants to get paid, they'll see that note that the paramedic put in there, the community paramedic put in there. And he's like, they really like have a good like bearing on patient care, which I had never really heard before.
Sam mentioned something early on about ACOs or accountable care organizations, and they'll use IH or community paramedics as an intervention that they will give to their insurance people that are penalizing them and saying, we're implementing this as a strategy
Mm-hmm.
to reduce this kind of stuff. And it is integral
Yeah.
to their
Very,
success. And
very.
therefore we get to do cool stuff.
And that's kind of
So
why we talked originally about there's such a spectrum. So, right, I think the people that do have this idea of, again, I'm not dissing on resource connection. That is huge. But there is these programs that are, and that's when I started this program, that's what I wanted from the bat. I said, I want to be as integrated into this as possible. So, right, everything we do is through our EHR system. So every note I make, the entire care team sees because we're a part of the care team. We're not an extension. And that's kind of my big spiel is putting paramedics into the care team is what, and right. So with that though comes a huge responsibility. You're not an extension anymore like we used to be with our 911 role where you can kind of say, well, I don't know I don't know. I don't know what these doctors are thinking. I don't know, and you can kind of wash your hands of it. Now you're completely deep dived into this care of this patient and this care team. You don't really have an excuse. So you have to learn how to have, right. I mean, you have to have the extensive knowledge of a lot of these different chronic conditions and then have the confidence to go out there on your own in these houses and not only discuss this with patients, but then start discussing with providers, internal med, with, people that are far more educated than I am. But the value you're adding, they do see that. And as you said, even with insurance companies, the reason our program development took so long was because we included our insurance companies, our liability companies, everyone that touches our patients or our providership, we had involved in our program development because we wanted them to see and right, how can we make this and maximize the benefit as much as we can? And that's the huge part. And that's why I think it takes more advanced provider when you have a program like that because you're pacing with people right in all different worlds of medicine.
Yeah. Cause it's like, Sam, to that point, we keep kind of shitting on it a little bit because you're right. Like, it's not like cool, but how cool
Right.
is it? You tell me this, how
Yeah.
cool is it for you to get on the phone with a primary care physician for Miss K and you
Hmm.
go, hey doc, I was here Monday and Miss K weighed this. It's
Yeah.
Thursday. She's 4 pounds heavier than she was. And her
Uh-huh.
12 lead kind of looks
Yeah.
starting to get a little ugly. I think I need to bring her on into you, not necessarily to the ED. Cause again, we're subacute. We're not at the emergency yet, but I see it coming. And I'm telling
Yep.
you, you need to make room at 4 o'clock today or at 9 a.m. in the morning to see Miss K and make an adjustment and either, get her, I don't know, dialyzed, whatever it is that you're going to do
Yep.
for her and see her in
Yep.
your heart failure clinic. Not every system has one of those. We were fortunate. The first program I did, we were fortunate to have one of those. We could bring the patient in through the back line and
Hmm.
get that patient resources what they needed so that they didn't call 911 and didn't go back through the ED. And in my opinion, I don't think there's anything sexier for a paramedic to be able to do than to go into
Hmm.
the home with no lab equipment whatsoever, take a set of vitals, take a weight and a history and predict, 2 weeks. I'm saying predict. That's a terrible word, but but to be able to look at this and go, yo, this is the path this patient's going down.
Hmm.
This patient,
trending.
say again,
Trending.
trending. Yeah, there it
There
is.
we go.
You can see that it is going this direction and you can intervene now.
Hmm.
Right. We intervene
Yeah.
now. And that's where to your point earlier, Mike, that's where all the risk adaptability comes from. That's where all of that, we don't have to get super crazy invasive in order to make this work. We just have to be vigilant and we have to do our jobs. We have to do the basics really,
Yeah.
really stinking well.
And I would argue, I think we have a skewed sense of what medicine is when you're in the 911 world because we're very skill-based providers. We're very, we're going there. We perform skills to save lives. That's not right, the big scheme of practicing medicine or being a part of a care team is a lot of basic stuff. Look at your family medicine providers, some of the smartest doctors I know, and intuition is insane. Not, they'll hand a paramedic a intubation tube before they're about to do it because, right, they're a little rusty. And I think people attribute skill to, our skills and our interventions to that's medicine. It's like, well, no, caring truly for the full spectrum and comprehensive care continuum of this patient is medicine. Seeing the depth of it, understanding chronic conditions and how those are going to play out. And right. And I will argue even knowing medications more than just our life-saving medications, going to the extent nature of knowing a lot of pharmacology. It takes a long time. I still, to this day, every day I run into a med, I'm like, gosh dang it, I don't know what that is. And got to go through and start studying that one. And right, it's much more knowledge-based. I would argue, and I'm sure you guys can attest to this, paramedics we learn skills and we learn them well because that is what's going to save this patient's life. We learn the knowledge when you're going through our programs, our knowledge. It's all right, let's get down and dirty. Here's what you need to know about pharmacology. Here's what you need to know about A&P. Here's what you need, we don't go through this depth of knowledge the way our providers do, that's because, right, we're going on these high acute situations. We need to know how to do our skills and do them well. But MIH is now transitioning into so now you have these providers that they know skills, they're good at it, but now we're teaching them this knowledge base. To me, right, you're turning into an incredible provider, now learning and also having still this skill base. It's unmatched. I truly believe there is no other type of provider than a really good MIH provider because you have something that, right, there's a spectrum, a really skill-based provider and the knowledge-based providers. You're mixing that together and you get someone that now is going into homes. Like I said, the impact's unreal.
Where do you guys find this thing going from here? It seems like it's really springboarded over the years. Where are we going from here?
Well, I hope out from under the DOT is my hope, but
shots fired.
No, I won't get on that one. But I do believe, I hope that MIH can prove that paramedics have a place in our healthcare system. And I hope that can not only transfer over just with MIH, but paramedicine as a whole. Pre-hospital paramedicine, whatever you want to call it, is a healthcare discipline and it should be treated as such. I think we keep trying to, right, we have these creative, MIH, it's a great framework. It's a great, but they're like, well, use grant money. I don't think you can always create healthcare reform on grant funding. I think we need to truly be recognized as a healthcare discipline with CMS and start going down that route. But like I said, we don't need to open that can of worms probably. But I do hope that it does give us a little more.
Another day and another bottle of wine.
Right. I know. But that's
Cody,
what I hope. I hope it gives us that.
Good. Excellent. What say you, Cody?
If I was looking into a crystal ball, I would say that progressive agencies will no longer be defined as flavor of the month interventions. A progressive agency will be the ones that have more MIH community paramedic stuff happening than they do system status management kind of 911 stuff happening, because they're going to get wise to the fact that, wait, you mean I could actually run an organization far cheaper if I put the best minds on the road and prevent the 911 calls and the other calls as well, right? The ones that inundate the system that make me have to you're never going to out-hire the healthcare problems in your community. Never. It's never going to happen. We tried it, 2020 hit, and we're still trying to catch up. Right? So this is the future of what, I don't want to say EMS because it won't be EMS anymore. I think EMS will become MIH. And I'm going to channel my inner, Matt Zavadsky with this stuff of we should have, because this is now 11 years ago, but we won't care about the volume of patients anymore. We'll have that under control, and we will be looking for ways, or we will be able to demonstrate a value to the patient, community, payer, system, whatever it is that you're looking for. We will be able to demonstrate a value to those people beyond transport. We will be able to demonstrate a medical benefit to those people, to your point, Sam, that are like, just get grant funding. They're going to be looking for, they're like, oh, what's the word I'm looking for? Damn it, I was on a roll. Will no longer be looking to fund these organizations with grant money. They won't. They will be budget line items, or they will be smart and use their transport revenues to back in to the MIH type programs and continually reinvest in those. I think that the days of, in my opinion, the days of you being a regular National Registry paramedic are numbered, because you need the depth of, I don't know, it could be an MIH or the MIH CP certificate, or CPCC, one of those two. Yeah. The white patch.
Yep.
It'll be board certification in that, or critical care paramedic, much like it is, in the world that I came from and the world that Mike is in, where just being a National Registry paramedic is not enough. You have to have the extra board certification of being a flight paramedic in order to be in this organization. Right. I think those single role type medics are going to continue to live in the fire department. Not that that's not a hit on the fire departments. It's just, it's not their mission. But the hospital-based and third service type organizations are going to put a big focus on MIH, I think. That's me looking. I would have said the same thing in 2015, 10 years later, and then here we are, building a new one. We're still building them.
Yeah, like it's the sustainability aspect. So I don't think anyone could argue you could spend a month shadowing an MIH program, an integrated MIH program. It's undoubtedly you see the impact. It's always going to lead back to, how do we sustain this? And like, that's kind of where I was going with the funding was, at the end of the day, unfortunately, that's what our healthcare system is built on. And EMS is right. It's just not involved. Every step of the way with program development was always, well, paramedics they're technically not healthcare providers under this legal aspect, under our insurance law. It's always, there's an extension. It's always this, there's these too many roadblocks for us to continue to progress no matter the impact. And I think that's why I never intended on really, going more on the, the policy side or learning more about that. But you kind of have to advocate for that stuff, because that's how we're gonna be able to sustain something like this. So yeah,
I'm fortunate enough that where I am, there's CMS has a line item for MIH treat no transport visits, and it's a minuscule reimbursement, but it's something. And it's you can move that needle in the right direction, and that's CMS. So when I was in Texas and we started this this was 10, 11 years ago, doing this, just hoping that we could recover billing for an AO998 HCPCS code. That's what we were hoping for. And it was so pie in the sky. And now, it's blam. Here's the white paper, and this is why we're doing it this way. So there are avenues out there, but to your point, Sam, we need somebody other than DOT, having these conversations with the insurance companies in order to make these sustainable.
Yes. Yeah.
Is an insurance company the same as an insurance company?
Is this Cody? Park on driveways, drive on parkways kind of thing?
That was me making fun of the Texas.
I know. Insurance.
Yeah.
Well, we've gone way over 45 minutes.
I know.
No, this is great. It's not like I have anything to do. Do you guys have any final, like Jerry Springer? Sam, I don't know if you're old enough to remember the Jerry Springer show, but he would always end with it. Jeez, barely. My God. It's like a 10-year medic watching Jerry Springer and he was still on. Actually, I'll tell a different story. I actually had a frequent flyer, since we're talking about MIH, or a high volume user.
Loyal customer.
Customer.
Was watching Jerry Springer, and her boyfriend were on there, and I was screaming at the TV on duty. True story.
No way.
But Jerry Springer always did a final thought. So do you guys have a final thought?
I don't know, Cody, you go first.
This is like when you panic order at the restaurant.
I
Like,
know.
oh,
Like,
no, wait, I was hoping you knew what you wanted.
what do I want to drive home?
My final thought is that the 911 world, the 911 system, it's not the only thing that you can do. And
Yeah.
I think organizations who are looking to build clinical capacity or capability within their departments and mobility for guys who, not everybody wants to be a fucking lieutenant or a captain. Not everybody wants to do that shit. Some people want to stay doing paramedic stuff, but
advanced.
They're tired of that. So let's move
you
them
can't
into...
read it, but my lieutenant badge is on the wall. It's not on my uniform anymore. So, yeah.
But yeah, so that's my parting thought,
Yes.
is a challenge of the leadership of these organizations to build that avenue of clinical advancement into your organizations for your paramedics, and watch perhaps a little recruiting retention number to fix.
Yeah. No, I agree. And I think it's funny. I just watched Alert Medics. They had a conversation with
They suck.
MSEC. Yeah.
I'm just joking. That's Cody.
That was
Cody,
Bourbon,
I don't
dude.
know if you know Cody.
They're great.
Cody's part of the pod. Cody's part of the podcast.
Oh, I enjoy them a lot. Well,
Yeah.
they had an incredible discussion, and at the very end, they talked about how, right, no one's coming to save EMS. We are the ones that are, right, our ideas are the ones that are going to make it the long haul and what it becomes and what it is. I think that's my kind of final thought, is you are it. We are it. As kind of corny as it is, it's so true. So keeping that curiosity, right, asking the right questions. I was one paramedic that asked the question to a whole hospital administration, and we created an entire program that's now helped over, just hundreds of people, patient contacts. It takes just one person to really do it, and it's maybe a little delusional, but that's why I do kind of believe that we can start small and make some really big changes, because, right, EMS is in its infancy. We still have, our roots aren't very deep. So we do have the ability to make the big change, but we all kind of have to be on the same board and ready to tackle it together.
All right. Well, thank you both for coming on. I'm going to hit stop. Don't go anywhere.